In this video, I'm going to talk with you about the silent killer. 30% of all people that are on Medicare today have to deal with a silent killer on a daily basis. It's called silent because in its early stages, there are no symptoms. But once those symptoms appear, usually it's too late, the damage has been done. And though this disease is manageable, it is rarely reversible. So in this video, I'm going to show you how you can avoid the silent killer, but if you already have it, I'm going to show you how you can manage it. So now you know what the silent killer is. It is diabetes. So we're going to talk in this video about diabetes. What exactly is it? Let me just give you a couple quick textbook definitions of diabetes so we're clear as to what the disease is. Number one, it's a chronic condition. Not acute, it's something that the majority of people will never recover from. Now, there are some people that have reversed it for sure through diet and different means, but the point is it usually is going to be a chronic condition. Again, oftentimes not diagnosed until there's already been some damage in the body, but it's a chronic condition that happens when your blood sugar, your glucose, is too high for too long. Also, it's a condition that prevents the body from regulating blood sugar levels, which again is going to cause damage to tissues and nerves and our organs. So it's a really a major health issue in America. And so secondly, what I'm going to talk about would be this. What does a person that has a healthy pancreas, who doesn't have diabetes, what is it that is actually going on in their body? So we put this chart together to kind of describe to you what happens in a healthy body. Number one, of course, from our food and things that we drink, we are getting carbohydrates, and those carbohydrates are turned into glucose or sugar that is certainly going to end up in the bloodstream. And so what happens when we have a healthy pancreas, we don't have diabetes, this pancreas is doing two things. It's actually producing digestive enzymes to break down the food, but also is producing a hormone that is called insulin. And so from the pancreas, we have this hormone that is designed to regulate blood sugar and, again, break down the food. And so what it's doing is this insulin is going into our blood, and this insulin is actually the key to make sure that this blood then is going to get the healthy things that it needs into our cells and into our cells, our tissues and our organs and our muscles. So that's exactly what it should look like right now. Of course, you saw my number, it was 84. I do not have diabetes, so this is how we want our bodies to function. But what happens, though, when diabetes develops? Here's what's going on, and all this is, of course, happening here in the pancreas as it relates to insulin. So first off, diabetes develops when the pancreas doesn't make any insulin, meaning it just stops totally. We call this type 1 diabetes. I'll talk a little bit more about that here in just a minute. But again, there's no insulin being produced at all by the pancreas because of a variety of reasons. Could be genetic, could be some kind of reaction to medication, maybe some pancreatic type issues. But the point is no insulin being made in this situation. Number two, doesn't make enough insulin. So it's still functioning, but it's not making the amount that the body really needs so that the blood is going to be regulated properly. And then number three, it makes enough insulin, but the body doesn't use it effectively. This oftentimes is called insulin resistance. So it's there, but not being processed well, and there's, of course, reasons for that. All right, so this is certainly what we don't want to happen, but when this does happen, then we have a diagnosis of diabetes. All right, now I want to talk about the different types of diabetes. Number one, we have type 1 diabetes. Now, just so you know, this is about 10% of the population of people that actually have diabetes. Right now, we have about 38 million people in America that have diabetes, and 10% of them, so a little over 3 million, almost 4 million, are going to have type 1 diabetes. And so what is that? Well, it's an autoimmune disease in which your immune system attacks and destroys those insulin-producing cells that are in your pancreas. And again, a variety of reasons, not always even known for sure. But this, of course, is the most serious one because the pancreas shuts down, and this is someone that is insulin dependent because pancreas is not functioning at all. All right, now type 2 diabetes. This type, the pancreas doesn't make enough insulin and or your body cells are not responding. Again, that's that resistance that's going on. And so still functioning, but not functioning properly. Again, we said there's 38 million people today with diabetes in the U.S. 10% of those are going to have type 1, and 90% though are going to have this. So this would definitely be the majority of people are going to have type 2 diabetes. And then we also have pre-diabetes. Now, these people have been not diagnosed with it yet, but their blood sugar is high. And there's some indications that they may be becoming diabetic. So let's look at the definition here. Pre-diabetes, this type is the stage before type 2 diabetes. Blood glucose levels are higher than normal, and depending on what kind of tests we're looking at, they're higher, but not high enough to be officially diagnosed with type 2 diabetes. Now, what's interesting about this group of people, folks, right now in America, they say 100 million people are pre-diabetic. And the sad situation is, and this is, by the way, the population between 25 and 64, but the sad thing is they say that 25% at least of these 100 million people will eventually become diabetics, all right? And so very, very serious. So that's the type of diabetes, type 1, type 2, and the pre-diabetics. All right, so back to the silent killer. Let's talk about the dangers of diabetes. There are multiple ones. So let's look at this statement first, because this really kind of really summarizes why diabetes is so damaging to our body. Blood glucose levels, sugar, that remain high for too long, an extended period of time, can damage your body's tissues and the organs. This is mainly due to damage to your blood vessels and nerves, which support your body's tissues. So when we have a healthy pancreas and insulin is doing what it's supposed to be doing, it is helping take that glucose and get it into our cells where it needs to go. But whenever we have blood that becomes high in sugar, what happens, it stays there way too long, and then as it flows through the body, then it begins to damage those organs because there's too much sugar that is getting to those organs through the bloodstream. All right. Now, also, I want to be very specific about things that happen in our body that we're very susceptible to, and that would be coronary artery disease. So we're talking about heart disease, congestive heart failure. Those kinds of things happen more likely. In fact, I think there's a 3 times more of a chance to have a heart disease when you're diabetic than if you did not have that. Number 2, heart attacks. Oftentimes this happens unnoticed as far as warning signs go, because the nerves are damaged by the diabetes, and people have heart attacks, and they're very massive. Because their nerves cannot pick up on those warning signs. So very unfortunate. Also strokes. In fact, interesting, just today, I had a call from one of my clients. I've been a client of mine for years, and she was going in for a knee replacement. And she was going to have her knee replaced, and then the day before, she actually had a stroke, and it's a pretty massive stroke. She actually is in skilled nursing right now as we speak. Sadly, she was a type 2 diabetic, was somewhat overweight, and she ended up having a stroke. And so very, very sad, but it's not uncommon with complications of those who have diabetes. And then number 4 is atherosclerosis, which is hardening of the arteries. I want to read this to you just real briefly about the seriousness of atherosclerosis. It's also known as hardening of the arteries. It's a disease that occurs when plaque builds up in the arteries. This buildup can narrow or block blood flow, leading to serious health problems, oftentimes strokes. And they talk about the causes of atherosclerosis: high blood pressure, cholesterol, smoking, physical inactivity, obesity, and diabetes. High blood sugar, what it does, it damages the inner lining of the arteries, which oftentimes is going to lead then to this very, very terrible disease. All right, next let's talk about some other dangers, and that would be neuropathy. Now, neuropathy, diabetic neuropathy, is when diabetes causes damage to your nerves. And it can affect different types of nerves in your body, including your feet, nerves in your organs, and your muscles. Why is this? Well, nerves carry messages between the brain and every part of our body so that we can see, hear, feel, and move. They also carry signals to parts of the body, such as the heart, making it beat at different speeds, and the lungs so we can breathe. So damage to the nerves can cause serious problems in different parts of the body for people with type 1 or type 2 diabetes. Okay, this article goes on to say this: neuropathy, this one we're talking about here, is one of the long-term complications of diabetes. Over time, high blood glucose levels, also known as blood sugar, these levels can damage the small blood vessels that supply the nerves in our bodies. This stops essential nutrients reaching the nerves, which means the nerve fibers can become damaged and they may disappear. This can cause problems in many different parts of our body depending upon the type of nerve that is affected. Again, a very, very serious issue, diabetic neuropathy. And then we have nephropathy. Okay, diabetic nephropathy. Now, diabetes, this is, of course, the damage to the kidneys. And this article says this: diabetes can lead to kidney failure because high blood sugar levels from diabetes damage, again, the tiny blood vessels in the kidneys, which are responsible for filtering out waste from the blood, causing them to malfunction over time and eventually leading to kidney failure. This condition is also referred to as diabetic nephropathy. So again, high blood sugar levels directly damage the delicate blood vessels within the kidneys, impairing their filtering function. Again, really, really terrible side effect of diabetes. And then retinopathy. Diabetes causes diabetic retinopathy by damaging, again, the blood vessels in the retina. The damage is a result of high blood sugar levels over time. High blood sugar levels damage the tiny blood vessels that supply the blood to the retina. So again, over time, the sugar excessive in the blood is going to cause problems to our eyes as well, glaucoma and such. And so these are very, very serious situations here. And then foot conditions. And this would be people that are just not getting enough blood flow to the feet. And you begin to see them swelling up, and there's sores and different things that happen. Very, very common. And then sadly, also amputations, especially in the lower extremities, because the blood's not healthy enough to supply good blood to the extremities. So we have amputation. So again, all these things are the result of diabetes. Very dangerous, for sure. All right, so that then brings us to how diabetes is diagnosed. Okay, it's very important that we, if indeed we have diabetes, that it's caught as early as possible to get control of it, but also to reduce the complications from it. So how do doctors and providers diagnose diabetes? So let's talk about this topic. Number one, healthcare providers diagnose diabetes by checking your glucose level, that sugar level, in and through a blood test. Okay. Now, so there's a couple different ways in which our blood can be tested. There's actually 3 different ways. So I want to share these with you so you can be sure to be proactive and make sure you're doing proper blood testing. So the first one would be a fasting blood glucose test, which means you haven't eaten for at least 8 hours. Many times people stop eating at night, and then they're going to have this particular test in the morning. And so they fast at least 8 hours. And so when they get a reading, here's what they're looking at. Okay. And so mg is milligrams, DL, it would be deciliters. And so they're measuring our blood. And if we have a reading of less than 100 milligram per deciliter, then that blood sugar level is healthy. Pancreas is working properly. Insulin is doing what it's supposed to be doing, and the blood is flowing to our tissues. So that is healthy if we have 100 or less. Then if we're between 1 to 125 milligrams per deciliter, that could be pre-diabetes. I mean, someone's in that range where there needs to be some concern if that's the reading. And then if it's above 125, 126 and above, they are definitely going to be diagnosed as a diabetic. Now, this would not just be one test. This would be tested a couple of times, but if both of them were above the 126, then more than likely they're going to be diagnosed as having diabetes. All right, the second form of testing is called a random blood sugar test. Just random. There's no fasting going on. Someone could do this at any time during the day, and the readings are not going to be as specific, but here's the indicators of diabetes. If it's 200 milligram a deciliter or higher, then you probably have diabetes. Very similar to the one I just did as I pricked my finger, and that reading was 84. I normally run anywhere between 85 to about 100 or so and as I check it, but the point is if it's above 200, more than likely a diabetic. Now, then we have tests, again, very accurate test called the A1C, stands for glycated hemoglobin. Okay, so this is the A1C test, and by the way, when people are diabetics, this is the one that they're recommended to get at least twice a year to make sure that they're very accurate. In the meds that they're taking, this A1C is very, very important. So again, twice a year at least. And so if we have a 6.5% higher in this particular test, again, 2 separate tests, then we are then considered to be a diabetic. All right, so you need to have your blood tested, any of these methods here, to make sure you know if you have diabetes. If you have it, then you're controlling your blood sugar as well. So that's how it's diagnosed. Now let's talk about mine. I actually just had a full physical, did a full blood panel and workup. And I thought it'd be interesting for you to see, not because it's mine, just because this is exactly what happens when you run these tests. And this, again, would be a testing of my blood. It was a fasting test. And so, but I want to read this to you because I thought this is very interesting. Here's what it says. As they checked through my blood work for glucose. The primary type of sugar found in your blood, glucose, measures your blood sugar at a specific point in time when your blood was collected. High levels of glucose may be a sign of prediabetes, diabetes, or other conditions. So very important. And you'll notice here that when they drew this, I was a 92. And so getting kind of close to 100, which would be moderately high, but I'm still in that, kind of the safe range. I'm not diabetic yet. But my whole point is that's what they're looking at first, this a range of your glucose levels. And then another test they ran on me was the hemoglobin. This was that A1C that we looked at. And so this is measures the average amount of glucose in your blood over an extended period of time, typically 8 to 12 weeks. High hemoglobin, A1Cs, levels can be indicators of what? Prediabetes and diabetes and other conditions. So this particular hemoglobin test is also used to monitor glucose control in people that have it. And again, that's what we're talking about. They need to have this done at least twice a year. Why? The goal for most adults with diabetes is less than 7%. Remember, because if we have 6.5 and above, we know we're diabetic. So we want to keep that within that range if indeed you already have diabetes. And so you'll see mine, not quite pre-diabetic here, I'm at 5.6. So the whole point is you want to be sure to be paying attention to your blood and the levels of that glucose within the blood through these different tests. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us a thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. All right, so once we've been diagnosed with type 1 or type 2 diabetes, we have to manage it. Very, very important to manage it. And so the goal, of course, is to keep those blood sugar levels as close to normal within that range. And we just said if someone's a diabetic, between that 6.5 and 7. Why? We want to delay or prevent complications because diabetes is certainly manageable, but it's going to take some work. It's going to take some effort. And if not, then your body is going to undergo some very serious health problems. So let's talk about how we do this. So first of all, we manage through blood sugar monitoring. We're paying attention to where our blood sugar is. We just talked about the different tests. And so one way that we can do this personally is through a glucose meter. That's what I just looked at. And so this is just a easy prick of the finger, put it on the little test strip there, and it told me exactly where I was. And again, we need to be doing this on a regular basis, especially if you're a diabetic. Or you can do what's called a continuous glucose monitor, CGM, and these are typically implanted right underneath the skin. And so this is something that I think normally will last about 6 months or so. And so this is something a lot of people will have because they want this on an ongoing basis and always have to prick their finger. So these can be attached to a receiver, could be going to an iPhone or some kind of a phone, so that you can continually see exactly what's happening with your sugar, especially when it's time to eat or the different times of the day. You want to be sure those sugars are in line. So a lot of people are going to use that. Very wise to monitor your blood sugars. Number two, second way we can manage, and very common, is going to be medications. Now, what you're going to notice here is we have oral meds, and this is typically when people have type 2 diabetes. Sometimes type 1 could, but there's no insulin that's taken orally. So these are just meds that are being used to be able to help the pancreas. It could be producing not enough, or it could be producing, but the cells and the blood are not using it effectively. So we're taking oral meds to do this. Very common, most common one would be metformin. Okay, and so people take metformin with type 2. But again, we're trying to manage it through oral meds. Now, if we have type 1 diabetes, oral meds, you're not going to take insulin orally. If you were to take insulin orally, your digestive enzymes would break that down. You don't want that to happen. You need the insulin to get into the bloodstream immediately, and so that's the whole point. So when I have type 1, I am insulin dependent. And then there's a couple ways I can take the insulin. It could be injections. I would just simply use a syringe and a needle and pull the insulin out of a bottle and self-administer that. Some people decide to do that. Others, for convenience sake, will use what's called insulin pens. and these have a little control to put the amount of insulin that's needed in the body, and of course then they will then put that in the muscle skin area, with that insulin pen instead of just a needle. And then some people actually have an insulin pump. So this is a continuous pump. It reads how much insulin is needed, and then it's just insulin coming directly from the pump. And so that would be a device that would be on the body somewhere. Okay. So the whole point is we may need insulin if we are type 1. And if not, maybe we can get by with just meds, but medication therapy is very, very important to the diabetic. All right, now let's talk about the different types of insulin. Because when we are on a regimen of insulin, there's actually 4 different types. Very important to understand how this works. Number 1, there's the short acting. This goes in the body and begins to react very, very quickly. Some of the brand names you may recognize would be Humulin, Novolin, and Afrezza. This is actually an inhaled type of insulin. But again, we're taking this because we need the immediate action. And then there's also rapid-acting insulin, Humalog, Novolog, Fiasp would be an example of that as well. And then intermediate-acting insulin, this is going to go a little bit longer. It doesn't hit its peak quite as quickly. It doesn't start working as fast, but again, is necessary to balance out what we're needing throughout the day. And then, of course, long-lasting, long-term insulin as well. The Lantus, Solistar, Levemir, Tresiba, and Basaglar. So the whole point is we have this variety of meds, and what may be effective for one person is not going to work for another. And so the doctors, your endocrinologists and docs, are going to recommend certain insulins because all these are going to work at different times in different ways as far as effectiveness and quickness and all those kind of things. So many times there will be a combination of these to be able to manage the diabetes accurately. All right, so that's medications. And then number 3, diet. Very, very critical. Again, there is no diabetic diet. As I studied on this topic for the video, they said probably if we had to identify a good diabetic diet, it would be a Mediterranean diet, okay? And so again, you do have to be paying attention because, weight control some kind of a weight where it's a healthy weight for you is very, very important, and diet's going to contribute to that. Plus, the food that you're eating is going to have carbs that are going to turn into glucose, and so you're going to make sure that you have very low sugar type of meals as well, low sugar foods. So low fat's the best. High fiber, fruits, vegetables, whole grains, lean meats, all that, very important. So you have to be disciplined if you're going to be able to control your diabetes through diet. And then also physical activity, exercise, walking, swimming, moderate aerobic. Should do it probably 5 times a week. It's just going to help you. That body fat that we carry can actually cause us to be more insulin resistant. Stop smoking. Make sure you get plenty of sleep. Watch stress in your life. All these things are contribute to our diabetes management. Okay, so we want to be sure that we're conscious of all these things. All right, that brings us then to the cost of diabetes. What's a cost? Very interesting stats on this. Number 1, in the U.S., and this is last year's number, there was $413 billion that was spent on care of diabetics. Tremendous amount of money. In fact, look at this stat. 1 out of every 4 healthcare dollars that is spent in the U.S. is going towards the care of someone that has diabetes. All right, so tremendous amount. Think about that. 25% of our whole healthcare system dollars going towards diabetic care. Now, watch this stat. Average lifetime medical cost of treating diabetes is $85,200. Okay, that's just the average. And so diabetes is very expensive, not just for insurance companies, but also for you as well. In fact, they say the average annual cost is about $19,700 for the average diabetic. So again, a tremendous amount of resources going to diabetic care. And I thought this was interesting. They say right now there's about 1.2 million new cases every year in the U.S., every year. Now, earlier I told you about there were 38 million people that have diabetes. That would be 10% of the population, type 1, 90% are going to have type 2. 100 million people are pre-diabetics. But here's what's interesting. As we think about people on Medicare, since that's what this is for, they say that of this number here, 55% of those people who have diabetes are Medicare eligible. Okay, that's almost 21 million people. And so again, diabetes, really the prevalent age group that's getting diabetes are going to be those that are Medicare eligible. So lots and lots of folks with it. All right, 1.2 million cases. So on the average, at least 30% of those new ones this year are going to be Medicare recipients. Now notice this. So we talked about really the cost of dollars and cents, but this to me is way more important, and that is this, that the life expectancy of a diabetic on average is 6 years less than someone that is non-diabetic. Right now in the U.S., the average life expectancy for a lady who makes it to 65, her life expectancy is right around 85. In other words, 50% are going to make it to 85. One-third will make it to 90 and beyond. For a man, that age is about 82. But if you have diabetes, average man would take off 6 years, and now we're looking at 76 years old for the average diabetic. And for a lady, normally it's going to be about 85. Now it's about 79. Okay, so it's rare then where a diabetic is going to live into the 80s. And it's just because the diabetes and the complications that come to the organs and to the tissues and to the nerves and all that high blood sugar is doing is hurting the body, therefore reducing the life expectancy. So again, very, very costly, not just in dollars and cents, but also in the span of our life. All right, so that brings us then to Medicare and diabetes. In other words, what's it look like when we're on Medicare and we are diabetics, either type 1 or type 2? So first off, Medicare Part B, you'll notice here, remember Medicare A is inpatient, hospital, B is outpatient. And so on the outpatient side, the B side of Medicare is going to cover the doctors that we see. It's going to cover different services as a diabetic. And so supplies and services cover, number one, your blood glucose testing supplies. What I just showed you there was a meter. The meters, the test strips, the lancet, all those kind of things, control solutions, that's helping us to be sure that we're monitoring our glucose levels on a regular basis. Again, is going to be covered by Medicare Part B. And then hemoglobin tests, those A1C tests, when you're going to get those twice a year at least, again, going to be covered by Medicare B. And then your insulin pumps. This is someone that is a type 1 diabetic, and instead of using the quick pen or syringes, it's going through the pump. And also the insulin that is used with insulin pump is also paid through Medicare Part B. And by the way, just so you know, a month supply maximum copay now is $35. I just changed a couple of years ago, and there's no deductible. So Medicare made some recent changes with the Inflation Reduction Act, and so they put a cap on insulin. So $35 is the max cap on a monthly basis, be $105 for a 3-month supply. All right, so Medicare Part B is covering that. Now, also, it covers foot exams. Why? Because, again, blood flow is not good to the feet oftentimes, extremities, the nerves, there's been damage, neuropathy and such. And so you can go into the doctor for proper treatment for that. And again, that's going to be Medicare Part B because it covers the endocrinologist, the podiatrist, and all the docs that are going to take care of you for your diabetes. And then therapeutic shoes and inserts, and then eye tests for glaucoma, as we read earlier, retinopathy, glaucoma. These things come to us more quickly because of the diabetes, because it's damaging all those blood vessels in the eye. So again, very, very important, but again, covered by Medicare Part B. Now let's talk about what's covered by Part D. These are your prescription drug plans. Drug plans are going to cover a couple things as well. Obviously, the medications to manage your blood glucose. That would be our oral meds, as well as our insulin. Now, if it's insulin going through a pump, then again, that's covered through Part B. But if I'm just self-injecting or I'm using the quick pens for my insulin needs, then that's going to be covered through your drug plans, those Part D plans. All right. Now, insulin taken by injection and necessary supplies. So everything that's related to the insulin, which would be my needles and the gauze and the swabs, all those things to make sure things are sanitary. All that is related to the insulin injections are going to be covered by our prescription drug plan as well. Okay, so whole point is Medicare covers very, very well through Medicare B and D. All right, now that we have an understanding of how Medicare works and what they're going to cover in regards to our diabetic needs, We're going to next talk about additional insurance, because the majority of people don't just have Medicare A and B. They have other insurance. And so when we do go on Medicare fully A and B, we have two different types of insurance options. About 40% of all people choose option number 1, and then about 50% or so choose option 2, and 10% just have A and B only. I wouldn't recommend that, but that's what they do. So both of these are our insurance options. So in this option here, number 1, this is someone that stayed in the original or traditional Medicare system. So they're falling underneath the umbrella of all the Medicare guidelines. But because Medicare doesn't pay for anything 100%, this is a person that says, I don't like all the liability that comes with the original Medicare, because Medicare only covers preventive services at 100%. Everything else that we're going to need, and all those things we need as a diabetic, there's going to be some co-pays, some co-insurance, some deductibles that we would have to pay. Most people don't want the liability, so they'll transfer the liability of those co-pays and co-insurance and all that to a supplemental company, private health insurance company, that will then issue a Medigap policy. Now, I'm not here to promote any kind of policy. I just want to make sure that if you have diabetes and you decide to stay in this system, how is it going to work? And so right now, as I shoot this video, January of 2025, the number 1 supplemental plan is the G plan. Number 2 is the N. They're both very good. You can't make a mistake, I don't believe, with either one of those. But just for the sake of this video and illustration, I'm going to talk about the G plan. It is still the top plan right now. And so we'll talk about how the G plan would work if we have diabetes. Okay, so here's what happens when we have a supplemental plan. Again, we're in the original Medicare A and B system. Part A is hospital. Part B is the medical side, the outpatient side, doctor side of Medicare. And so in each of these, we have gaps that we're responsible for. You can see we have an A deductible and a B deductible. We have co-pays for extended hospital stays, co-pays for extended skilled nursing stays. We have 20% co-insurance and the possibility of a doctor adding to the bill called excess. This doesn't happen often, but when it does happen, they add 15% to the bill. My point is this: we have gaps in Medicare, 3 gaps on the A and 3 gaps on the B. So if I'm a diabetic and I have a supplemental plan G, what's that going to look like? What will I be responsible for here? And here's what's going to happen. All the gaps are covered, but once a year you would have to meet the $257 deductible. Now, you're going to have to pay a premium for that G plan, and that varies, state to state. It's very reasonable, but you're going to pay that. But beyond the $257, once a calendar year, you're done. So in other words, if you're in the hospital, it's not going to cost you any money, no matter how long you're in, up to a year and 5 months. You go to a skilled nursing facility for 100 days, it doesn't cost you anything. 20% co-insurance fully covered, excess charge fully covered. So again, once a year, you'd be billed up to the B deductible, and then that would be it. You're done. You truly have full coverage as long as you're going to a Medicare provider and you're getting a service covered by Medicare. Other than that, you have a full coverage plan. And so people with diabetes oftentimes like that kind of situation because, again, they are spending money. Like we looked at earlier, what average cost right now, almost $20,000 for the average diabetic. So what can they do? They can transfer the majority of that away to an insurance company. All right, so some people decide they don't want a supplemental plan. They actually will get what we call an advantage plan, or they're called replacement plans. Now, I still have to enroll into Medicare A and B. I've got to pay my B premium for sure. But now, instead of original Medicare being the one that's overseeing and directing and managing my care, now I have a private health insurance company, and they have what they call a managed care plan by a private health insurance company. There's lots of them right now, and there's actually about 4,000 Advantage plans in the U.S. For 2025. And so these are also called C plans, Advantage plans. And then with them, they embed a prescription drug plan. Over here, we had a separate drug plan when it comes to our, the medications. But the whole point is this is an option that about a little over half of all people have decided. So if we're diabetic and we have selected an Advantage plan, let's look and see how that coverage is going to work. Hey, if you come to a place where you know you're going to have to make some Medicare decisions pretty soon, the best way to do that is to click up here in this right-hand corner, and you'll have an opportunity to be able to book a call with one of our Medicare guides. All the guides around here I have personally trained, and they truly are professional. They'll answer your questions, and they'll show you different Medicare options to make sure that you're confident in the decision that you make. And so what I did for the video, I'm not promoting any kind of company whatsoever, so you're not going to see any kind of company names here. I just want you to be able to see how this system works. In fact, let me just go back for just a second. One of the differences, there's several differences between these plans, but over here I pay a premium and a small deductible and I'm done. Over here what I do is I pay as I go until I hit a certain max out of pocket. The majority of Advantage plans today don't have a premium. I got to pay B still, but the insurance company usually doesn't charge me a premium to be on their plan, because instead of paying a premium, what I'm doing, I'm just simply paying as I go, co-pays, co-insurance. So if I'm a diabetic, that's what I'm doing over in this system. So let me show you exactly how that's going to work. All right, so first off, this is, again, I just chose 3 companies. There's no names listed here. These are just very, very popular companies. But this particular plan has a 0 premium, meaning you paid Medicare, you're $185 a month, but after that, no premium. And so what the company does is this one does not have a medical deductible. Some do, some don't, usually don't. But they do set a max out of pocket. So I pay as I go, co-pays, co-insurance for a variety of services. I'll show you that. But the max, if I stay in my network, is $3,700. And so that's your maximum exposure on this particular plan for the whole year. After I've met my $3,700, then the plan is going to pay everything at 100%. Also, if I happen to go out of my network, this plan will allow it. It's a PPO plan, but my out-of-pocket goes up to $6,200. That's why whenever we go on an Advantage plan, we always like to make sure that the doctors you're seeing or would like to see, hospitals you want to go to, are going to be in the network. By the way, that's one of the differences between supplemental plans. Supplemental plans don't have networks. They're open access. You can go to any provider, any hospital, any doctor that takes Medicare, they will take your supplemental plan. But here, such is not the case. They're voluntary. They don't have to take them. Most docs will take some of the plans, but usually not all of them. And so we have a financial limit there on this one. Now you're going to notice your doctor visit, your primary care doctor, 0, go out of network, 25. Specialist, so you go to your podiatrist or you see the endocrinologist, for your diabetes help, then you're going to pay a copay of $25 in network, $70 if we go out of the network. Okay, and you'll notice that's what always happens. If we go out of our network, these cost us a little bit more. All right, so that brings us then to some other details, being a diabetic. We're certainly going to have some durable medical equipment, things that we're going to need because of our diabetes. And so you're going to see we pay 20% co-insurance as long as it's a durable medical equipment provider in network. And then our diabetes management. And again, we talked about these things, the monitoring supplies. Now notice on this particular plan, if you go and use this AccuOne Touch, it was 0 copay for those supplies. If you go somewhere else, it's going to be 20%. But again, you have this very small, reasonable financial responsibility for your diabetes, either 0 to 20%. All right, let's look at a second company here. Again, another company. Now their plan wasn't 0. They actually had a premium of $40.90 a month. And you'll notice also they have a deductible. This year it's $257 for certain services. Remember, the other plan was 0 deductible and also a 0 premium. This one a little bit more. But also notice what happens on this one. You have a max out of pocket of $9,350, and so a lot higher than what the other one was. And so you're supposed to be paying attention when you get an Advantage plan, what will your max out of pocket be? Okay, now whenever we go to a hospital, what's going to happen is going to cost us $2,165 copay for regardless of how many days we're in. That's what we're going to be out of pocket. Most of these companies charge a daily copay. This one just charged a flat amount. Regardless of the days that you're going to be in. Now, why would we need that? Well, if we had some type of a issue, complication with diabetes, we may need to go to the hospital. So we're going to be out of pocket that. And then let's look at one other aspect of this, and that's going to be this company. Remember how we talked about going to our primary care doctor? The other one was 0, specialist was, I think, 25. Here, we pay 20% co-insurance. So if the doctor visit is $200, we're going to pay $40. The plan pays the rest. Telehealth, 0. Specialists, again, our podiatrist, our endocrinologist, other docs, you're going to see, again, 20% of the cost of that as well. All right, then when it comes to durable medical equipment, you're noticing here, what do we have? We have 19%, unless we get it at a pharmacy. Sometimes you can, sometimes you can't. Glucose monitors, monitoring supplies, these different things, again, somewhere in the neighborhood of 20% or 0. When it comes to durable medical equipment, 19%, medical supplies, all these kind of things. Again, you're seeing what's happening with the Advantage plan. You're paying a certain percentage. We pay as we go until we hit the max out of pocket. All right, just one more real quickly, and this will be the last one I'll show you, but I want to make sure you see. Now we have another company, and again, 0 premium, 0 deductible on this. Notice the network, in-network, $4,150. $5,750, very similar to what that first plan that we looked at. So that's going to be our max out of pocket for the year. Now again, if we go to our primary care doctor, 0, go to specialist, $30, go out of network. Now we have 45% co-insurance. So again, the importance of the network. All right, so on this screen, we're looking at a situation where we're put in the hospital, meaning we have some kind of complication going on for something, and now we're in the hospital. This plan charges a daily copay. Remember the other plan? It was just a flat little over $2,000 regardless of how long. This one is $330 a day for up to 6 days. 7 days thereafter, it's going to be $0. Now, certainly you want to go in network for sure, because if not, you've got a network, you can do it. But look what that's going to cost you in the hospital, 45% of what the bill would be. So you would never want to do that. Durable medical equipment, again, 0 to 20% coinsurance, kind of like the other plan was. Your glucose monitor, 0. And so again, we have a very reasonable out-of-pocket expenses for these kinds of things as well. All right, so that brings us back to our options that we talked about earlier. So what you can see between these two here, this is more of a premium-based coverage. I pay a premium for the supplemental plan, transfer most of the risk away, very little out-of-pocket beyond maybe a small deductible. So I'm paying a premium over here. It didn't have a premium. That one had about a $40 premium, but again, very reasonable. Both of these I'm enrolled in A and B, so that's the only thing they have in common. And so in this system here, I'm just simply paying as I go. Again, very reasonable copays up to a certain limit called, of course, the max out-of-pocket. Now, another difference between these would be, again, we talked about networks. Here, we're going to have an HMO network or a PPO network. Over here, we have no network. It's open access, go anywhere. As long as they take Medicare, they will take your supplemental plan of choice. Also notice the drug plan is standalone. It's separate. You picked it out. You had a premium for it as well, or it could be low or 0. But this one over here, the Advantage plan actually picks the drug plan out for you on your behalf. So depending upon the insulins that we're taking, depending on the medications that we need to manage our diabetes, we're going to make sure whatever way we go that they're going to be in the plan's formulary. Okay? And then there's one other thing that's really, really critical, and that's this. If I go this direction, I will never have any kind of insurance interference. We call that a pre-authorization. Over here, it happens about 70% of the time. With Advantage plans, they have the last say-so. They have the final decision, the final say-so, with about 70% of your services. Now, you can go to your primary care doctor without a pre-authorization. You can get regular blood work without a pre-authorization. But if you're going to have a surgery or planned in hospital stay for surgery, or an MRI or a CAT scan or a PET scan, certain things you're going to need, in this system, it has to be approved, pre-approved by the insurance company. So doctor recommends, and then the company decides whether you get that or not. And many times they approve things pretty quickly. But sometimes they delay the approval or flat deny it and say, we're not going to cover that. All right, so that's called a pre-authorization. So we have that here, but we never have it here. Why? Because the insurance company follows Medicare. If you're seeing a Medicare provider and Medicare says they'll cover it, doctor says you need it, end of story. The insurance company has no say-so whatsoever. They follow Medicare. So again, that's the difference. Also, these plans are annual plans. These are lifetime plans. So again, as we think about the plans and your diabetic care, you also have to look and say, okay, how's my insurance going to work if I had diabetes? And one of the interesting things about diabetes is we know that it's very expensive. We saw last year was $400 and some billion. Do you realize that over 50% of the money spent on diabetes is going towards complications? It's because people, their diabetes gets elevated to a place where it's causing damage. We talked about kidney damage, kidney failure. So when people have the kidney failure, they're either going to be on dialysis or going to have a transplant. Very, very expensive. Okay, and so you have to decide if that happened to you, what service, which one of these insurances would you like to be on if it happened? We know that amputations happen in lower extremities, especially because of diabetes. Again, that's a complication that is going to be very, very expensive. And so you have to ask yourself, which system do I want to be in? All right, okay, now let's talk about the last issue here, and then I'll close out the video, and that's this. Oftentimes, people may be on an Advantage plan, and they would like to switch over here to a supplemental plan. All right, but what happens if I've been on my Advantage plan for a year or 2 years or 5 years or any length of time, and I want to move off of the Advantage and I want to go back over here to do that, you have to go through medical underwriting to make that move. And so it's possibility that if you already have diabetes here, and it's especially with some complications, that you may not be able to make the move. Because after we have been on Medicare, Part B, for 6 months or more, in order to make a switch to get back over here, now we have to go through medical underwriting. So I'll close out the video with this very important fact about switching off an Advantage and moving to a supplemental plan, what is involved. And you'll notice what's involved is this, medical underwriting, okay? And so how will diabetes impact medical underwriting? All right, so in other words, the health questions that you're going to have to go through to get that supplemental plan are going to include questions about your diabetes. All right, so notice what it says here. It says here, answer these questions if you're applying for underwritten coverage, which you're going to need to if you're getting off Advantage, moving this up. It says if any health questions are answered yes in Section 4, and this is just part of Section 4, the applicant, notice, will not qualify for this insurance with us, meaning they're not going to approve your policy. So this is someone that's in Advantage, and they would love to move over to a supplemental plan to get rid of networks, get rid of pre-authorizations, to have a permanent policy, to be able to have predictable cost, all that. But we have to ask health questions. So this is part of those health questions. Let's read it together. They say here, have you been medically diagnosed or treated by a member of the medical profession for diabetes? Okay. And they don't specify whether it's type 1 or type 2. They're going to go ahead with further questions. So have you ever been diagnosed with it, and that requires the use of insulin? Well, who is that? Well, that's going to be our type 1 diabetics. And so if we say yes to that question, what happens? You're not going to qualify. So this company will not take an insulin-dependent diabetic. Next question. So you have diabetes with complications. So this could be somebody over here. This is type 1. This could be someone with type 2. Okay? They have type 2 diabetes, they're not insulin dependent, but they've had complications, retinopathy, neuropathy, some of that nerve damage, peripheral vascular arterial disease, heart artery blockage. Why? Because that high blood sugar is causing these problems. And again, if they say, yes, doc, diagnose me with that, you're not going to qualify to have a supplemental plan. History of a heart attack or a stroke. Notice, at any time, if you're a diabetic, you can say yes, you're declined, and then treated with medication. Now watch this one, that has been changed or adjusted in the past 12 months because of uncontrolled blood sugars. Things have happened, and now you're having to take more medications or different medications. So any disruption in meds in 12 months, you say yes to that, you're not going to be able to get approved to get that supplemental plan. You're going to have to stay on your Advantage plan. All right, let's look at one more just quick example because I want you to understand really how serious this can be. Again, just another company. You don't even know who they are. I didn't mention it here because it doesn't matter. But I want you to notice, watch this. If applying during open enrollment or a guaranteed issue period, go to Section F, meaning skip the health questions. When you first go on Medicare, that is called your open enrollment. And so during the 6 months of your B date, 6 months prior or 6 months after your B date, you're in this window where there's no underwriting allowed by the insurance companies. They have to take you. Even if you have serious diabetes and you have even complications, 6 months of your B date, before or after, they have to approve your policy. Now, if I apply 6 months in advance, my plan's not going to start until my B goes into effect. But if I haven't started a supplemental plan by then, I still have 6 more months of my B date to get this with no underwriting at all. That's called the Medigap open enrollment period. All right, now watch this. If not, meaning you're not in open enrollment, guaranteed issue, where they can't do underwriting, now it says here, if not, please answer all the following questions. Notice again, if you answer yes to any of the following questions, again, you're not eligible for coverage. And so again, here we come, diabetes. If you have diabetes or take prescription medication to control your blood sugar, have you been medically diagnosed with or treated for any of the following conditions? So some other issues going on besides diabetes: peripheral vascular disease, peripheral venous thrombotic disease, peripheral artery disease, kidney failure, kidney disease, stroke, mini stroke, TIA, congestive heart failure, any heart disorder whatsoever. Okay? And then it says if you do not have diabetes or do not take prescription medication to control your blood sugar, this question should be answered no. Okay, so again, they're just saying, but if you have diabetes and you say yes to this question, you are not qualified for a MedSup plan. If you have diabetes or take prescriptions to control your blood sugar, do you take 3 or more medications, different types? Because some people take multiple medications for their diabetes. It just happens. And so notice 3 or more oral or injections to control your blood sugar. If you don't have diabetes, that you say no. Of course, if you have yes, you have 3 or more medications, you say yes to that, they're going to decline your application. And then the last one, if you have diabetes, take prescription meds to control your blood sugar. Do you take 4 or more medication to control your high blood pressure? I've seen this happen before, meaning the damage because of diabetes to those blood vessels. Now they're having difficulty getting your blood pressure controlled. And if you're taking 4 or more, which is a lot, but if you again said yes to that, any one of those would be declinable. And so my whole point is this: if you have diabetes, when you first go on Medicare, it could be your once and only opportunity ever to get a Medicare supplemental plan, and you don't want to miss out on on that opportunity. All right, I'm going to close out the video with a report that came from Mayo Clinic. And I thought this is very interesting because this is a Q&A through the Mayo Clinic services. And they said, how does diabetes affect the heart? In other words, what is the connection between diabetes and heart health? And here's what this article says. The number of people worldwide with diabetes is rising. While many may not realize it, diabetes comes with a higher risk for heart disease. Research has shown that people with type 2 diabetes are up to 4 times more likely than the general population to die from cardiovascular disease. Diabetes can damage blood vessels and make the heart muscle stiffer. This eventually leads to problems with fluid retention and heart failure. People with diabetes also have a higher risk of premature accelerated coronary artery disease. This means that compared to those patients who do not have diabetes, the walls of the arteries have more fatty deposits and begin to harden earlier and without many warnings, making treatment difficult and causing the condition to progress faster. Subsequently, people with diabetes with an increased risk of recurrent heart attacks and scarring of the heart muscle, which increases the risk of sudden cardiac death. After a heart attack, the heart muscle does not heal as well as in people who do not have diabetes. Due to nerve damage caused by diabetes, patients may not feel the chest pain or other types of chest discomfort that may signal something is wrong with the heart. So heart disease may not be detected until it is advanced and fewer treatment options are available. They also may suffer silent heart attacks because of the lack of warning signs. They may not know that they already have an advanced stage of the disease. Heart disease and diabetes share similarities beyond their potential complications. Both typically require taking medications to achieve and maintain optimal control. Medical treatment regimens, particularly over the years, can become complex with the use of multiple medications. Ongoing research also shows strong evidence that weight loss can reverse diabetes in some patients and that lowering blood pressure can reduce the risk of developing diabetes complications. Positive lifestyle changes such as quitting smoking, losing weight, exercising more, following a healthier diet, and controlling blood pressure, all of these can contribute to better diabetes control and heart health. Studies have shown that by achieving good control of these cardiovascular risk factors, people not only significantly improve quality of life, but most importantly, prolong their lives by an average of 8 years. Heart disease and diabetes are chronic conditions that in most cases cannot be cured, but with proper guidance and management from your diabetes care team and heart health expert, you can go on to have a productive and more healthy quality of life. And so here's my point, folks. Diabetes is serious. It's very costly. Financially, it's also very costly to your health. And so do everything you can if you have it to manage it, and if you don't, do everything you can to prevent it.